bukan scroll test. Jadi bisa diakses.
Selamat sore everyone. Terima kasih sudah hadir untuk mengikuti kuliah tamu hari ini, guest lecture dari Prof. Menzies. Baik yang datang offline maupun datang online. Sore ini sudah hadir dengan kami ada Prof. Menzies dan juga Ibu Santa Soliquid dari McGill University Montreal, Kanada. Dan juga alhamdulillah kegiatan hari ini juga dihadiri oleh ketua Pusris ya, sama aja director, head, chair, semua sama oleh Prof. Basi Aliana dan juga oleh salah satu peneliti senior di pusat riset C3ID, Prof. Rusman. Jadi alhamdulillah kita panjatkan kepada Allah Subhanahu Wa Taala karena hari ini kita bisa berkumpul, mudah-mudahan bisa menambah ilmu untuk meningkatkan kemampuan kita dalam membantu usaha kesehatan masyarakat. Jadi hari ini agak spesial dari guest lecture yang biasa diadakan oleh Pusris C3ID UNPAD. Kami kebetulan bekerja sama juga dengan program studi Magister Epidemiologi FK UNPAD. Di sini ada beberapa alumni-nya ya, dan juga baru saja lepas. Dan juga mungkin di online juga ada beberapa mahasiswa S2 Epidemiologi. Jadi ini kerjasama kuliah tamu ini diadakan C3ID dengan pusat program studi Magister Epidemiologi FK UNPAD. Harapannya adalah ke depan kuliah tamu seperti ini akan mungkin diadakan ya, dan bekerja sama dengan banyak pihak supaya share informasi makin meningkat gitu. Sebelum kita masuk ke kuliah tamu guest lecture, before we start the guest lecture from Menzies, we would like to hear from Prof. Bati Aliana about C3ID, probably briefly, and then what is the current update or what is the next from C3ID? A little bit, probably 5 minutes or less. Yeah.
Tes 1, 2, 3. Ya, selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Happy to have you here, Dick and colleagues from the Canada. Bahasa Inggris, bahasa Indonesia bingung. Okay, so maybe a little bit in English. I hope our colleagues, our staff can follow. This is a very good event now that Rick Menzies is here to give us the guest lecture. I think this sharing corner or this time for sharing corner will be used for this instead of also the research result that you have done. Jadi hari ini kita mendengarkan kuliah tamu ini kesempatan yang bagus sekali. So for samping ini kemungkinan banyak tamu-tamu lain yang bisa membantu kita dan memberikan pengetahuan kita lebih banyak. Yeah, for Dick, I think for our research center is getting bigger now. There are several big studies in diagnostics and in vaccine trial and diagnostic. There's also new diagnostic, but also secondary diagnostic for drug-resistant TB, and so it becomes more strength, more powerful, and more more spread the expertise in TB, and there are more principal investigators that comes from the next generation. The generation of Lika and also the junior of Lika. There are more PIs. Maybe sometimes you can meet them. They are not here yet. Maybe online. Yeah. So thank you very much for being here. Dan terima kasih pada semua teman-teman yang sudah hadir di sini. Semoga kita semua bisa belajar bersama-sama tentang laten TB. Karena Prof. Menzies adalah orang yang paling update tentang ini. Okay, thank you. That's all from me. Yeah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi thank you very much for Prof Menzies for opening and also welcoming really Prof Menzies. And then the next is Prof Romi because of her contribution and her expertise, we can work together with Prof Menzies from McGill University, Montreal. And this Prof, yeah, you can use the key. Thank you.
Hidupnya nggak ke sana ya, ke sini.
Iya, ya, ke situ.
Kece.
Ya, ya udah. Merah.
Udah. Ya, terus.
Yeah, sure.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Selamat sore semuanya. I will make a very short because Basti and Lika already mentioned. Buat semua, kami bekerja sama dengan Prof sejak 15 tahun yang lalu. Berawal dari sebuah proyek dan tadi sempat nostalgia sedikit, benar-benar Prof masih ingat bagaimana waktu awal kita nggak punya klinik, kita nggak punya apa-apa, we have nothing, we work at BPKTM, dulu namanya BP4, but then over the time, years, yesterday I took Dick to our facility. Dick can say himself that we are really making a progress toward a positive way. The aim of Prof come here to Bandung because we have a new study together, still not far from CPT. Then Prof come to really see if our site is ready to run the trial. What they call in GCP is SIV, site initiation visit, to really check whether we are good to go. And then I believe by tomorrow, Prof will release the letter, official letter, very brief this one. It's called by a go letter. Then kalau kita sudah dapat surat itu, bismillah kita akan berlari, tapi awalnya pelan dulu, lihat situasi. Nanti kalau misalnya sudah oke, kita baru larinya lebih kencang. Dan mudah-mudahan, dan saya sangat yakin, tim penelitian di FC3ID ini sangat komited, sangat berintegritas, menjaga kualitas. Kalau enggak, mainnya marah soalnya gitu ya. Dan saya sangat yakin teman-teman di lapangan akan mampu menjaga amanah ini dengan sebaik-baiknya. Nah, hadiahnya adalah ya Prof ini orang dunia banget. Diperlukan, WHO sering sekali meminta untuk panduan apa gitu, meminta McGill untuk menyusun ininya, dokumennya. So we are very lucky to have Prof Menzies here. It won't be the last, ya Dik ya? It won't be the last. We still have another 7 years to go. Semoga kita semua bisa menangkap esensinya. If you look at the title, from 12 months to 1 day, is it feasible or it is just fantasy? Jadi selamat menikmati zaman dari Prof. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Yeah, thank you so much, Prof. So before we begin, sorry. So the outline of this guest lecture, it will be start from lecture from you, and then followed by the discussion. So from offline or online, you can raise a question by chat or by raise your hand, so we can unmute after we finish the talk. So from for everyone who doesn't know him, please look at his publication, look at his work. He's the most leading expert on TB disease and TB infection, and then also with the diagnosis and also with the preventive treatment. Yeah. For how many years? Don't know, you can tell. He's pulmonologist and epidemiologist as well. Yeah. So time is yours. Yeah, please.
Okay.
Okay, so thank you, Lika. Thanks, Bhakti and Nina for inviting me. It's definitely a pleasure to come back. I honestly can't remember what year it was that I was first here, but I think it was around 2014. maybe?
Here? 10.
2010. Okay, so 16 years ago, my first visit here, first trial in collaboration with everybody here. And yes, there's been a huge progress in the last 16 years. The place has grown. Every time I come, there's new signs for TB here, TB there. I'm sure if I worked in cancer, I'd be very sad to come here because you can see there's no sign of all these other diseases. They've all disappeared. And all the rooms that used to be for other problems are now taken over by TB. But as a TB investigator, I'm very happy to see this. So congratulations to everybody in the room, but especially to the leaders for really building this unit into a very, very strong and really internationally recognized research center. And I mean that sincerely. I heard people who don't know that I've worked in Indonesia I met them at the union conference in Copenhagen, and they were saying, "Oh yes, there's this great place in Indonesia. You've probably never heard of it, etc." And Bandung. So indeed, I didn't know of Bandung before I came here in 2010. I had to look that up on the map where I was going, but now everyone knows where Bandung is. So I'm gonna.
Yeah.
So I'm gonna kind of give this talk. Yeah? No, I think it's okay.
Ya, kedengeran di sana.
Right. I muted myself on the computer so I could talk on the microphone.
Ya. You guys can.
Otherwise, there's this. Yeah. Okay. So, of course, I'd be happy to have questions at any time, but I think the plan is I talk and you listen and then you talk. So you have to wait your turn. Okay. Now, so a little outline. So first, I wanted to talk about very briefly about testing. And I'm talking about this in part in light of some discussions we had even the last couple of days where everybody thinks that you don't need to test for TB infection. So I'm going to first talk about that. And then a short history of TB preventive therapy. And I've put on the right a column of kind of my rather rough estimation of when the trials were done. And INH has been our sort of standard therapy forever, it seems. And then the alternatives in chronologic order as they were investigated and then recommended and used and so on. Okay, so first, again, why test for TB? Again, a lot of clinicians in many parts of the world will say, why bother?
No need.
No need. That's a waste of time. Even, I would have to say, there are some at WHO who say that, despite my best efforts. Okay. So the first is, so this is a very old study, well, very old, 1974. Published a large cohort of US Navy recruits who were followed for 4 years because that's how long they have to serve. So very good cohort study. And they tested them at entry and they looked at how many people developed TB. And you can see that if they had a negative tuberculin test, so that's on the left side, very low rates of TB. And if they had a positive test, you would see. And really, so a positive test is a much higher rate of disease than a negative test, right? Very simple, but forgotten. This is a much more recent study where, again, an individual patient data meta-analysis with about 150,000 people in the data set. So a large data set. And the red line is risk of TB disease in people without treatment over 5 years with a positive test, mostly TST. The green line is positive test but treated. So you can see treatment does reduce the risk. And the blue line, which looks very close to zero, I think almost everybody in the room can struggle to say that that's above zero. That blue line is people with a negative test. Otherwise the same. Immigrants, HIV, whatever. So doesn't take a rocket scientist to say, gosh, there's a difference there. Looks like the red group is in trouble. and the blue group is in pretty good shape. So anyone who says you don't need a test, just call that graph up and show that. And this is, again, a large study. So this is child contacts, which is perhaps more debatable. But here, too, you look at risk of disease if they're test positive, whether it's TST or IGRA, or test negative, and you see, again, quite a big difference. Of course, child contacts, they're very young, they're very small, things can happen fast. So we do often treat despite a negative test, but you can see that there's still a big difference. Okay? And then this is a review postdoc at McGill did, and we just looked at the relative risk or incidence rate ratio, for those of you who studied epidemiology, between people who had rates of disease if they were test positive, rates of disease if they test negative, and that 11.0 in words is among HIV infected persons, the risk of disease is 11 times higher if they're test positive than test negative. Okay, so very high risk if you're test positive. Okay, maybe not no risk if you're test negative, but clearly the test identifies the priority groups for treatment. So that's why you should test. Okay? And then finally, the last sort of nail in the coffin of do not test is these older studies where they had placebo controls and they looked at the relative risk of disease if you're test positive and treated or test negative and treated. Okay? And it's always any drug versus placebo. You can't do this nowadays because we don't do placebo-controlled trials. So what you see is that if you're TST positive and you got treated, your relative risk is, compared to if you got placebo, is 0.38. So a substantial protection from treatment. But in the group that were test negative, a slight drop, but no significant protection from treatment. And a big study in Botswana that was after this had analysis, same result, 92% protection if you're test positive, 14% protection if you're test negative, which was not significant. There are, of course, exceptions. That's why we do systematic reviews and meta-analyses. Your professor of systematic reviews will tell you. Why do you do it? Because,
Not yet.
oh, not professor yet, sorry. Your expert in systematic reviews will tell you that there's always noise. There's always, by chance, a study can find nothing. That's why we do significance testing. So indeed, there is a study where this was exceptionally not the case. But again, the vast majority of studies, clearly the benefit of treatment is in the test positives. Again, why is that? Again, there is some risk. You can't say there's zero, but it's low and they don't benefit from treatment. Okay, so test. All right, now turning to preventive treatment. So again, I asked this when I was giving this lecture or a lecture a couple of days ago. For those who were in the room, okay, you don't have to answer the second time. But for those of you who weren't there, who's taken antibiotics in their life? Almost everybody's taken antibiotics. When you took antibiotics, did you have testing before to make sure you have side effects from the treatment?
Apa dia, Ben? Kalau pakai antibiotik, dicek side effect dulu nggak? Tes.
Did the doctor say, here's 2 weeks of antibiotics, come back after a week and I'll make sure there's no side effects? Did that happen? Did you have blood tests to make sure you didn't have side effects? No. Right? So that's what we want for TB preventive treatment. Something that you don't need to test before. Did the doctor also ask you, are you on this medication, that medication? No. You want something that you can give no matter what other meds they're on, and you don't need monitoring, you don't need to come back. Here's a prescription, take it. So that's what we're after. So that's Starlet trial is shorter and safer. The motto of our whole trial is safety, 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 safety. Okay? Why? Not because, it's a nice motto, but if you have something that's really safe, it will be acceptable, it will be easy for patients, for providers, for programs. Okay, so So TB preventive. So the short so I'm now going to kind of go over the story. And to many of you, INH really probably seems like it came from this sort of era. But I can assure you it's slightly more modern than that. but nevertheless, INH dates back to the 1950s, INH preventive treatment. Okay? In the first discoveries, there were many trials. And why 12 months? Again, there were multiple trials, but this is one of the bigger trials and best trials. And what you see is that 12 months of INH was better than 6 and better than 3. And they had two groups. They had all participants and they had so-called completer compliers. So in the completer compliers were defined as every visit that came every month, and the staff did pill counts. So then the research staff in the room, you know how tedious that is. 28,000 people had pill counts every month for a year, or 6 months or whatever. And the people who took 80% of doses every month, 93% protection. So very good. That's hard to beat, right? So 12 months of INH became the standard from this trial. Okay. But what about safety? So one of the interesting things, and one of the reasons that our current trials, we emphasize safety, is that in the 1950s and 60s, there were many randomized trials. A total of more than 100,000 people received INH in these randomized trials. So a huge population. But amazingly, they did not notice drug-induced hepatitis. And this is all about who gets into randomized trials. What kind of people get into randomized trials? They're eager volunteers. They're very concerned about their health. They tend to be more compulsive, etc. So they have good, what we call good health behaviors. In any event, in 1971, INH was enthusiastically recommended in the United States, promoted and encouraged, and within a year, there were outbreaks of INH hepatitis, including deaths from INH. And unfortunately for public health in the US, the biggest outbreak of INH hepatitis was in Washington among politicians. Yeah, and at least one journalist died. Yeah. So, quick now, what do you think the risk factor among US politicians? Now, of course, there are politicians anywhere, but let's think of US politicians.
Soju.
Exactly. So that was the common factor, but had not really been recognized.
Yeah.
Anyway, okay. So outbreaks. And so what happened after that was, of course, nobody wanted to give INH, right? It was very famous. I mean, a politician getting INH hepatitis, naturally, a senator, whatever, in the hospital. Oof, that was news. So no physician was daring to give INH for decades. So it really dampened efforts considerably. Okay? So the other thing is, we think of TB drugs, you know, they're not so bad, right? So here are antibiotics and the rates of hepatotoxicity. So amoxiclav, clavulin, again, I don't know what it would be called here, very commonly used antibiotic at home. So that's 1 to 17, depending on the study. Hepatitis per 100,000 people that take it. That's pretty rare. And interestingly, that telithromycin had 17, they took it off the market for 100,000. And trovafloxacin had 6, whereas levo has almost nothing. But now, what do you think the rates are with INH relative to those rates?
INH?
Yeah, what would you think?
Compared to?
Well, compared to those numbers up there, like 17 that was taken off the market. And INH is not taken off the market.
Higher.
Higher, but how much? Like 20? 30? Who'll give me 40?
Ada. I got
Okay,
I got your slide.
You saw them already. So you see, like crazy high rates of hepatitis.
Yeah.
Okay, so that's partly why we're looking for new drugs. Because even rifampin, which I It's a personal favorite, of course. That's still not great. Okay. And INH, again, has been subsequently shown among HIV-infected persons, deaths due to INH hepatitis among pregnant women. And in Quebec, we looked at it, 45, about 1 in 200 are admitted to hospital for drug-induced hepatitis. And in the elderly, 2% are admitted to hospital for drug-induced hepatitis. So I know that INH is commonly used, even still here. It should not be. It is not a good drug. Okay. And the last is when people look. So I have heard people say INH is not a problem in Africa. They're younger, whatever, you know, they don't get INH hepatitis, they don't die. So then someone actually looked. That's the problem. No one looks, you don't detect. They die at home. When they actually looked closely, so this would have been like a PEPFAR program. So almost 4,000 treated with INH, 60% completion. And you see this 6 hospitalized and 4 died of liver failure. So when they actually looked, there were deaths. So there are probably deaths. Just no one is counting. Okay. So yes, so do not use INH anymore. Anyway. Well, I shouldn't say do. We use it as a secondary drug. It is used occasionally when you really have no other option.
As alternative.
It's an alternative after rifamycins, after fluoroquinolones. It's like your last choice. So INH is effective. Liver toxicity is common. It can cause hospitalization and deaths, or as we say in Canada, liver deaths. So if people get liver transplants, they don't die. But still, a liver transplant is not a good outcome for a young, healthy person taking preventive treatment. Okay? So that is why the push away from INH. They're really important toxicity. Okay, so option 1. So one of the first alternatives that was brought out was this PZA and rifampin for 2 months, which you've probably never heard of. So I'll tell you why. So the impact of safety, again. So this is you've heard the INH story, now the 2RZ story, or in the US, 2RZ. I'm not sure how you pronounce Z here.
Z.
Z? Z, okay. All right. So between 1990 and 2000, there were several randomized trials of this treatment, all in people with HIV. And it was excellent efficacy, in fact. And this was also demonstrated in a mouse model. Very efficacious. So people were pretty excited about it. And in 2000, this regimen was enthusiastically recommended, promoted, and encouraged. Very much like INH had been 30 years earlier. And lo and behold, within 1 year, there were widespread reports again of drug-induced hepatitis and deaths. Recommendation was withdrawn, continued controversy, and again, another black mark on TB preventive therapy, right? It just kind of recovered from INH. People were starting to use it again, and then whoops. So again, why emphasize safety in your trials? Trying to avoid this kind of story. Okay, so 2RZ is off the table. What about INH and RIF? So this is, so there was, again, an older sort of ad campaign for a new aspirin, a coated aspirin. And the ad was all about why trade your headache for an upset stomach? Take a buffered aspirin. So with 3HR, my question is, why trade INH hepatitis for drug interactions of rifamycins? Why trade when you can have both with 3HR? So 3HR in summary. So there's relatively little evidence from randomized trials for 3HR. It is obviously very easy to use because it uses the same fixed dose combination as for active TB. So almost all programs in low and middle income countries have the drugs right there. And everybody knows what they look like. They know the doses. So it's programmatically very easy to use. It has about the same efficacy as 6 months INH, but it has the same toxicity as 6 INH. And I just spent 10 minutes belaboring the point that you don't want to use INH, so I'm not sure you'd want to use it for this either. And you do have the added problem of drug interactions. So I do not recommend 3HR. I admit that WHO recommends it. It's, yep, I didn't mean that one, but I really think it should be avoided. I note that it's not recommended here, and I'm happy to see that. Okay. So in Canada and the US, it's really not used either. Okay. So what about 3HP, which is recommended here and is being implemented here? Okay. So this is a pretty good regimen, and this trial, large-scale trial, published in 2011. And in fact, Chantal and I were involved with this trial as a site in Montreal. And what you see is that TB disease with 3HP was lower than INH, and in people who took the full course was very low. 1 in 1,000 developed TB disease, less than 9 months INH. So it looks very efficacious, okay? Which is remarkable for 12 doses. Okay? And there was animal studies and so on and so on. But the problem is this. So hepatitis is less. So 9-9H had a kind of predictable rate of hepatitis, and 3HP much less. But still, drugs were stopped for adverse events, and grade 3 to 4 adverse events were very similar. So we didn't actually have necessarily a safer drug, but less liver toxicity, but there were other problems, this kind of weird hypersensitivity, which occasionally could be very severe and land people in hospital. Okay, so again, I'm not dwelling a lot on 3HP. Excellent efficacy and completion. 1 point, all doses should be directly observed. Completion rates are clearly lower if self-administered. I know that many programs are going with self-administered, but there is good evidence that it's hard to remember once a week pills, truthfully. Most people have trouble with it. And there are safety concerns. So overall rates of drug discontinuation for adverse events, 5 to 8% in most studies, so fairly high. And severe adverse events and hospitalization is about 1 per 1,000. So that's still not, it's not quite where we'd like. Okay, so now what about RIF? So here is the study that we started on here in 2010 and was published in 2018, which says something about how long it takes to do randomized trials. But it was a large scale, 6,800 adults and about 800 children. Completion was much better with 4 months of RIF, 9 months INH. Rates of TB were low and non-inferior. In fact, in children, the rates were actually lower with 4R, but wasn't significant. And then adults, they were about the same. So efficacy was the same, and safety, yes.
No, just to be properly said that kita terlibat dalam penelitian. I'm proudly say that again. Thank you.
Yeah.
Okay. That was a paid political announcement. So the big difference was safety. And so there you see highlighted the rate of hepatotoxicity, 2% with INH and 3 per 1,000 with RIF. So, and that was a significant difference. The other adverse events were pretty similar and, fairly low rates. So the overall rate of adverse events with 4 RIF is about 2.5%. And it's typically in all the trials we've done, it's run about that rate. So and that's drug discontinuation for adverse events, around 2.5%. So it's certainly significantly less than 3HP. So it appears safe. It's not to say there's no adverse events. Of course there are, and there's certainly rash. Okay, so we did a systematic review. So in green is the 4R. So 28 cohorts, so not just the randomized trials, but other studies. And again, pretty low rate of grade 3 to 4 events, severe events, less than 1%, and 3% drug discontinuation. 3HP, you see much higher rates of severe and much higher rates of drug discontinuation. And INH, of course, I've already told you about, also has the most deaths. But still otherwise quite similar to 3HP in overall safety profile. So I would say we still need a safer regimen, ideally shorter, but also safer. Okay, we also did an individual patient data meta-analysis, very similar. Bottom line, 3HP was better completed, but 4R was safer. Okay. So summary of 4R, very good efficacy and completion, lowest rate of liver toxicity, some rate of allergy, and of course drug interactions are the big limitation of rifamycin. It is a problem in older populations. Okay, now to R squared. So this was a trial to look at high dose RIF. Again, when we launched the trial, which was ultimately published with Prof. Nina as the lead author in Lancet Respiratory in 2024. But when we launched the trial back in 2018 or so, as we were planning it, high dose RIF was a lot of interest in high dose RIF as potentially a solution to shorten treatment. And so we compared 4 months standard, 2 months double dose, and 2 months triple dose. But the priority was to look at safety and tolerability first. Was it okay back there? Okay. So this was the trial design. Again, a 3-arm trial. RIF for 2 months, double dose or triple dose was blinded to the individuals. And the results, very simply, double dose RIF appeared to be as safe. So that blue on the bottom is kind of the overall rate of our primary outcome, which was severe, grade 3 to 5, or any grade rash allergy. About 2.5% with 4 RIF, very much as usual. 20 milligrams double dose was about the same, but 30 milligrams was clearly not as safe. It was significantly less safe. And there was other evidence that triple dose was not well tolerated as well. So our conclusion, double dose RIF, I didn't show this, very good exposure based on PK studies, but no difference in safety, so it was as safe as the standard. There was no difference in symptoms reported on routine question, but there was worse completion, which can be an indicator of subtle tolerability. Triple dose rifampin was worse in all parameters. So it was worse in the primary outcome of safety, it was worse in terms of tolerability, and worse in terms of completion. So that clearly, it passed some threshold, and triple dose rifampin is off the table. And then, so now we're on to daily rifampin. So daily rifapentine is interesting. So rifapentine, which is the P in 3HP, is first of all turns out to be 4 times more potent, milligram per milligram, 4 times more potent than rifampin in terms of just in vitro killing TB bacteria. It also has a 5 times longer half-life. And so when you give daily rifapentine 600 milligrams, which is the same as daily rifampin dose, we end up with 3 times higher drug levels than daily 600 milligrams RIF. And so, again, just back of the envelope calculations, 4 times 3 times, you should have about 12 times more activity with daily rifapentine than daily rifampin for the same dose. So, first, there have been studies in mice, which I'll show a bit later, that 1 month INH rifapentine is the same as these other regimens that are currently used. 1 month levo and rifapentine also the same. And 6 weeks of rifapentine is predicted to have the same efficacy. But I think theoretically is kind of interesting, which is that it should be much more potent, milligram per milligram, and therefore allows substantial shortening. So we've gone from 12 to 3 to 4, and now it looks like 1 month is feasible. Right. We've got a couple of regimens there that look like 1 month. Okay. So before you go home, though, we're going to see if we can get lower. Now, so 1 month has been tested, 1 HP. The first study was published in 2019. HIV infected people, a large study. They jumped to a phase 3 trial. TB rates were equal in the 2 arms. So it looks efficacious. So 1 month of HP as efficacious as 9 months of INH, which is essentially our gold standard. Okay. But what about safety? I'm glad you asked. So hepatotoxicity, which is the evil, thing that hangs over us all, 2% with 1 HP. So 1 month, but still 2% rate of hepatotoxicity and 3% with INH. Drug discontinuation, despite the hepatotoxicity, was a bit less, but still was similar as INH. No significant difference. That p-value column, no significant difference in safety with INH. So is that good or is that bad?
Is that good?
Anybody? Who says good? Put up your hands. Everybody's afraid. Huh? Who says bad? Want to put up your hand now? So why is no significant difference with 9-INH bad? Well, because 9-INH, we know the profile. It's got a bad toxicity profile. You don't want a regimen that's about as safe. You want something safer. So when you see those non-significant p-values, you want to see things that are lower and significantly lower. For RIF, if I lined it up, everything would be less than 0.001 in the right direction. Okay? So there's a problem still here. The fact that it seems low is just a reflection of the methods and the population. Yeah. And probably nobody was drinking alcohol.
Yeah, because it's less.
Okay. So someone tried 1 HP in Taiwan, an older population. Okay. 490 adults, 1/3 over the age of 65. So yes, so that's definitely an older population. Completion rates, 1 HP and 3 HP were good. The systemic drug reaction and causing them to stop treatment. 13% stop treatment because of these drug reactions. So that's a high rate. Like 1 in 8 stopped the treatment. And 3 HP also high. Again, it's an older population. So we moved to Brazil. And again, this is a center in Brazil that is also collaborating in our STARTA trial. But this is a trial they had completed, just finished. It was published just before Christmas 2025. 500 people in Brazil randomized to 1 HP or 3 HP. Again, you see the completion rate is good, but grade 2 adverse events, 16% 1 HP. Drugs stopped for adverse events, 7%. So again, not a good safety profile. Okay. To my mind, not what we're looking for. Okay, so 1 HP. So it's recommended by WHO. A lot of people have received it. It is not very hepatotoxic. I mean, the brief trial it had more hepatotoxicity than subsequent trials. It is very effective. But the disadvantage is there's clearly issues with safety and tolerability. I don't think we can go any further in terms of increasing the dose given the tolerability. So you can't get much further shortening. And high pill burden also is discouraging. and no LAI, which stands for long-acting injectable, which is, of course, what the next option has. Okay? So 6 weeks of rifampicin. So this is without INH or levo, so just monotherapy. And again, monotherapy should always be safer, theoretically, but it's a bit longer, as you see. And all we know is that so far enrollment is 1,600. And after 250 per arm, interim safety analysis, no concerns. After 550 per arm, trial may continue, but repeat safety analysis in 1 year, which was not planned. So I'm not sure if there's a safety signal. Okay, so then there's 6 weeks of levo rifapentine. The idea, so that is what we're testing in Starlet. And the idea is simple, that we are replacing INH, which is substantial rate of hepatotoxicity, with levo, which has a much, much lower rate, 1,000 times lower rate of hepatotoxicity. Of course, are we trading that for some other problems? We don't know, but we know in a trial where levo was given alone for 6 months, there was no significant difference in severe adverse events compared to placebo. Okay, so now we turn to kind of the final, what might be the final chapters in the story, and that is these drugs. So bedaquiline is a diarylquinoline, which is fortunately abbreviated as DARC. So I'll refer to them as DARCs, mainly because I can't pronounce diarylquinoline more than twice. Okay, so bedaquiline has been around for a decade at least. I think 2012 were the first studies with it, and it's been in much more common use since about 2016. So there's extensive use. It's available throughout the world. It's child-friendly formulations, safe in pregnancy. There's a lot of advantages to bedaquiline because it's been used so much for MDR-TB. But it has never been tested as monotherapy for TPT. It does have very good potency in vitro. It has very long half-life, which is always a problem in terms of safety. In the mouse model, 1 month of bedaquiline seems to be about the same as 1 month, 1 HP. So it does look to be efficacious. And 2 weeks of double dose appears to be as good as 1 month HP, and so suddenly you have the promise of 2 weeks instead of 1 month. Mind you, at a fairly high dose. And there's a formulation, long-acting injectable. So you can take basically 1 month worth of bedaquiline and inject it into someone. I'm told it's a fairly painful injection, for a day or two, but nevertheless, that's it. I was going to say they walk away, they probably limp away, but nevertheless, they're done. The only thing is that long half-life has people worried, because you put it into someone, you can't take it out. And it's a very long half-life. So if they have a side effect, I don't know, like terrible nausea, it's going to go on for a very long time. So that's still an issue, and why, it has to be very stepwise to get there. Okay. So safety, bottom line, there are safety concerns. We've looked at the safety of bedaquiline using our IPD data, and we found that bedaquiline had one of the lowest rates of drug discontinuation for adverse events. But those, admittedly, are MDR drugs, which are notoriously toxic. So we're still not completely clear. But breach, which again, you've heard about. So this is kind of breach after Donald Trump. So what you see is that bedaquiline rollout evidence in contacts, people living with HIV, prevent TB, breach TB. So there's people from Hopkins, and there's people from Lima, Peru, centers there. And there's a couple of centers in Africa, in Tanzania and Uganda, and that's it. Basically, Trump and others cut the budget severely of Smart for TB, and so really all they're able to do is a relatively small number of centers and really just a phase 2 trial. So they're doing something similar to Starlet in that they're trying to look at safety really first in about 500 people. And they have this very complex diagram because they're looking at context of drug-resistant TB and drug-sensitive TB. It's 1 month of bedaquiline, and they're looking at safety and completion. The long-acting injectable, since I promised to talk about one day, so the long-acting injectable for bedaquiline is now in phase 1 trials, and these phase 1 results were presented at the Union Conference last November. So phase 1 trial is usually healthy volunteers that get a fair amount of compensation, and they get the drug. So they got this injection, and first they got a relatively small injection, 2.5 ml, and then 5 ml, and then 2 times 5 ml, 2 injections. And then they're followed. And they're thinking the most effective, of course, is the bigger dose, 2 times 5 ml. Okay. So interim safety analysis, bottom line, although you read the numbers and there's a few things that might make you worried, hypotension, obviously a lot of pain, especially with the bigger injections, of course. But not bad. There was one with agranulocytosis, which I'm a little worried about, but otherwise, nothing too major. Okay. So they're poised. So bedaquiline, so again, extensive experience, 4 weeks daily should be effective. Mouse data, I'll show you that briefly in a minute. 2 weeks at standard dose, probably not enough, but at high dose appears to be very effective. So there's a possibility of a 2-week treatment. And then there's long-acting injectable. Of course, the generic oral bedaquiline is available from global drug facilities, so it's relatively affordable now, something like $40 for a month. So it's, it's not, it doesn't break the bank. On the other hand, in Canada, we can't afford it. It's something like $30,000 for 6 months, which works out to $5,000 for 1 month of treatment. So you can enjoy the benefits here, but due to patent laws, et cetera, we cannot. And of course, the patent's supposed to be over, but it's never over till it's over, really. And the long-acting injectable, again, for high-income countries, it's under patent protection till 2038 at least. And who knows what will happen that in low and middle income. Likely it'll be cheaper, of course, but we don't know the price. Because it is still owned by a private firm. Okay, so here's the last option that I'm going to talk about. And this is a 2nd generation DART. And this is the one that we are hoping or planning to test in Starlet. So sorfecolin. So one thing I learned in the last 6 months is that you can now literally design molecules. And in fact, there are people using artificial intelligence to design new TB drugs. So you can take bedaquiline and you can say, okay, there's a QT problem, and the half-life is too long, and they know what in that molecule does that, and they tweak it. It looks quite changed to me. It looks kind of quite different, but they do things to it, chemists, and now suddenly it doesn't have QT effect, and the half-life is less. So I personally still find that amazing that they can some chemists can figure that out and do that. They can design the drug, but all of this, and they ended up with a drug with 10 times greater potency as well. So when they do in vitro cultures, serial dilutions, etc., it takes 1/10 the dose to achieve the same killing of TB as bedaquiline. So 10 times more potent, no QT, and shorter half-life. So it looks like a substantial step forward. phase 1 and 2 trials. So this drug has been through phase 1 and phase 2, Sorfequilin. The mouse data I'll show you. Basically, phase 1 studies that appear safe. There was myopathy in 2 persons, whether they both had circumstances that maybe explained it, but nevertheless, there was maybe a signal there. But otherwise, it seemed great, no QT, and in TB treatment, again, it appeared safe. So I think it's ready for the next step. So for those who haven't heard about Starlet, shorter and safer treatment for latent TB. It's a phase 2 adaptive trial funded by CHR. Total planned enrollment 1,800, 9 sites in Canada. So we're trying to enroll a lot of people in Canada. Why? Canadians tend to be older, more comorbid illnesses, getting latent TB treatment at least. So we see a lot more side effects, a lot more difficulties with the treatment. And of course, also international sites, Benin, Brazil, Indonesia, and Vietnam. Of course, there you still see the full spread of range of ages, etc., but on average, ages are low. The interventions are 4R10, that continues to be our standard. Our first experimental regimens are 1 LP, so 1 month levo with pentine, and 2R20. And the third experimental regimen, which will be added, we hope, in January, February of this coming year, is Sorfequilin. And I'll just show you a schematic. So this is what an adaptive trial looks like. So you start with some regimens, you run for a while, you do an analysis, and the worst performing regimen you drop. And you add another regimen. Okay? And you can, in fact, continue. The rate limiting steps are first your patients with regulatory agencies, because every time you have to get through the regulatory and ethics committees, but also funding. But the hope is we keep going with this until we find something that's really short and yet also really safe. And then we go to phase 3, and hopefully we have one short, safe, and proven efficacy that we can recommend, etc. Scale up. Okay. So how are we doing for time?
We have another 5 minutes.
Okay. Okay. Well, I'm going to go very briefly just to say that. So one novel feature of the Starlet trial is the design, the adaptive, etc., stopping and starting. The other is that we have, very fortunately at McGill, investigators who are basic science types and clinical types like me. And so the basic science types work in the lab with mice and test regimens, and then they tell me this looks good, try it out, and then I say, no, either that dose is great, really well tolerated, can we maybe think about a higher dose, or no, that didn't work. People, that was not safe. Obviously, it's not like overnight, but there is a bit of a feedback loop, and that usually doesn't occur. So here is some of the results from this Dr. Lupien. So first, she tested 2R20 against 4R. So this is a regimen we've already tested. Basically, what you see is that by 2 months, double dose RIP achieved complete killing, and the relapse rates, which you see over there, 47% and 40%, seem high, but in fact, those are very acceptable relapse rates. The 4R, 6 months INH all have very similar relapse rates. So that's okay. So basically, she showed that 2R20 was good in the mouse. She went on to look at HP and is that with HP and LP, by 1 month, everything was gone in all the mice with both regimens, lungs and spleen, complete eradication of bacilli. And yet, 3 months later, after treatment finished, 60% of HP relapsed, 40% of LP. So LP did look a little better, not significantly, to very small numbers of mice, but very good eradication. So they do also both seem to be efficacious in that mouse model. And now finally, here's surfactant and the other drug. There's a drug with a number, TB8587. Not that you need to know that, but they're basically two drugs, very similar structure. We're looking at both in the animal model. In case there's a side effect with surfactant, we could turn to this other drug. Bottom line, in fact, by 4 weeks, they were very close to the limit of detection, and by 6 weeks, completely gone.
So which one is green? Which one is blue?
I don't know. They're basically superimposed. There's really no difference between the two. We're waiting for the relapse data. The thing is, these drugs have such a long half-life that in fact, it is possible that 2 weeks, we could have stopped at 2 weeks, and because of the long half-life, it just keeps going and going and going and going, and would have been enough. So we'll know that with the relapse data. If 2 weeks doesn't look like enough, right? Still very high levels. Even 4 weeks doesn't look like enough. But if the relapses are 0, it means, in fact, it was killed after you stop treatment. It keeps on going. And that is what has been shown with bedaquiline. Part of bedaclin's efficacy is that you can stop at 4 weeks and it just keeps going. The problem, of course, is always the safety keeps on going too. Okay. So again, just in the mouse model, bedaquiline, 1 HP, very similar. Okay. And this is the relapse rates. So here you see the relapse rates of these regimens. And I would just note that 4R at 4 months, 46% relapse. INH at 6 months, which we consider, and right, that's the standard WHO recommended regimen, 100% relapse. It actually takes longer. And 3RH, which again is a recommended regimen, 54% relapse. 3 HP, 47%, and so on. And 1 HP, 60%. All right, so these relapse rates seem high, but they're acceptable. And these are results from McGill, very similar rates of relapse, very similar to what they've been getting at the other centers. Okay, so this is just to say that 2 weeks of bedaquiline at double dose achieved very similar results to 4 weeks of bedaquiline at standard dose. I'm not going to show more than that. And the long-acting injectable, the biggest dose, that 2 times 5 ml, is the black line. And basically, what you see is that after the injectable, the bacterial counts just keep going down and down and down and down and down and down and down. So it really does keep working. That's 3 months and it's still working. 1 injection. Okay. So that's why they work 1 minute. Okay. All right. So surfactant. Disadvantages of surfactant is we have limited safety data and we have no data in kids, pregnant women, breastfeeding, etc. We're really starting new. Excellent efficacy, seems to have very good safety so far. And importantly, the long-term patent is held by an NGO, the TB Alliance, that is committed to making the drug affordable and accessible. We live on donor money. And the donors give money so that they can develop drugs so that they're in there free, cheap. That's the model. So for us to test that drug, frankly, makes sense. It almost guarantees that if we're successful, the drug will be available at a low cost. The other thing is, this too has a long-acting injectable formulation already developed. It's not as far along in testing, but preclinical studies have started. But it is available. And here's our study timelines. If we go with surfactant, so you saw the 3 arms, surfactant, the 4th arm might be 2 weeks or something else. The 5th arm, we hope, will be the long-acting injectable, and then we'll move to phase 3. And December 2033, will be done. and then we all retire. Okay? So conclusions from 12 months to 1 day, fantasy or current status. So again, we've gone from 12 months to 3 to 4 months, no problem. That's established. There are many regimens of 1 to 2 months that are out there that are being tested. 1 HP is, it's recommended. There are, I think, some safety issues. There are also possible regimens of 2 weeks. High dose bedaquiline, perhaps sulfaquiline, we're about to find out. And then there's one-shot TPT. Okay. And that really looks plausible. So again, from 12 months to 1 day, fantasy, I would say feasible.
Yeah.
Okay. So again, some of the things that have brought this about, AI design drugs, really a whole panoply of in vitro testing now that is very established, well-validated mouse model, really helps move things faster. And then we know the phase 2 trial, platform trial to test multiple regimens, I think is a way to accelerate development, get things faster. And we will ultimately, I hope, be able to take the best regimen in phase 3. Thank you. Only 7 years to go.
Yes, thank you so much, Pak. So the answer is already fill up. The answer is feasible. Yeah, it's not fantastic. It's feasible. We still have time. 18 minutes probably before we close the guest lecture. So is there any question from the offline of one from Marcel and Pak Basti 3? Why is boys? Why
Where's
are
the girls?
boys? Where's the girls?
Where's the girl?
So Marcel, Pak Basti, and Ezra. Ada door prize-nya. Ezra tahu.
Oh my God. Ezra terakhir.
Padahal pertanyaan.
Yeah, you can also pick some snacks. Panitia organizing the community also allow you to eat or drink it while we discuss. Please, Marcel, you want to come here? Yeah. Yeah, supaya yang di Zoom kedengaran. You can introduce yourself.
Hi, hi everyone. My name is Marcellus. Currently working in University. I did my PhD in Oxford, General Institute, Muslim vaccine. Really interesting talk. I've never worked in drugs before. But I'm interested asking you on have you ever compared head-to-head between the current the current trial vaccine, the M72 versus TPT? They're both only graft positive patient, right? I know that the phase 2 report is like 50% with a really long conflicts of interval. But what do you think? Will combining both improve each other? Will combining both make it more harder to dissect?
So, sure.
Anyone?
I have other questions, but maybe others.
Okay, so let me answer that first. So that's an interesting question for sure, and one that people are thinking about. If the vaccine is effective, but 50% effective, then you can see that there would still be a role for TPT because high-risk people, you would want the extra protection. So I can see that there will be certainly need for trials combining the strategies, maybe cluster randomized trials, and who knows the design. But I would think that there would be scope for combining the interventions and looking at that.
So not comparing, but combining.
Well, yes.
Yeah,
So you could
Either.
design a trial where you're combining. So you've given the vaccine to a large group of people, and now you're maybe randomized to TPT and placebo. That might be ethical, and see whether the TPT did add or just added toxicity.
And toxicity. Yeah, Pak Basti. So you will be the fourth.
Yeah, I think I'll just
Okay, Pak Basti, please.
Thank you. Yeah, maybe a clinical question. Let's say you are working like me in Indonesia, where the TB transmission is very high, and then you have a diabetes patient and maybe a lupus patient who will get steroids. Those are very high risk of having TB. And but right now in the program, there is no guidelines that we have to give TBT to those people,
Sure.
even though they have a high risk. Let's say they're young, maybe with high risk. And I know that in diabetes, maybe the risk is not as high as the lupus patient having steroids. So would you give them, even though the national guidelines is
Sure.
not there yet? Thank you.
So obviously, I don't want to comment on, say something that would go against national guidelines, but the hope is that, we've looked at risk benefit ratios. If you take INH, the risk benefit ratio is, favoring treatment only when you're like 35, right? And older people, it's not as beneficial because the risk of toxicity goes up with age. But as soon as you put rifampin in there with its lower toxicity, the risk benefit ratio, the balance is when you're closer to 60, as an example. So, and that's in people who are low risk. So clearly the safer the regimen, the more it favors giving TPT to lower risk people. I think that the priority in, again, if you have limited resources, the priority is always the highest risk. So HIV, kids, contacts, that sort of thing, as per WHO. But if you can get a treatment that is cheap and is 2 weeks or less, you can just prescribe to people like that. Someone says, you're a contact, you're a contact, you're a contact. Okay, we give it. We'll just give it like that without worrying. You have a diabetic, you screen them, TST positive or whatever, you treat them without really a whole lot of questions. The idea is to get it into primary care as well, get it out of TB clinics and into the hands of primary care doctors worldwide and nurses, even better. So that then you really start to see scale up. And yes, people could take it and then 5 years later they get exposed. Well, no problem, take it again. That's, why worry? You worry when it's toxic or it's lengthy, but you worry much less if it's short and safe and simple. So that's the drive.
Okay, thank you.
Yeah. Exactly. Probably we can also check.
Yes. Yeah.
You can also check yours.
Thank you for a great lecture. So two simple. I just have two simple questions. The first one is regarding the mouse model research that you show. There is relapse case. What is the definition here in the relapse case? Because this is from what I know that latent TB is not yet active, right? So what does it mean by relapse?
Sure. So again, this is a mouse model, obviously, which is a bit different from human. And the reason that we like the model is not so much that it exactly mimics human latent TB, but that the results with treatment really seem to mimic phase 3 trials. So in the mouse model, they have a stable chronic level of infection that is quite substantial, 10 to the 4, 10 to the 5th bacteria. So it's quite high, but it is stable. They can live, they appear asymptomatic. I mean, what's an asymptomatic mouse? I don't know, but they eat and play and do those mouse-like things. So the mouse can live for months in that state. And if you treat them, of course, these bacterial levels are from sacrificing the mice, obviously. So the relapse is you treat them for 3 months, then you stop. And then you wait 3 months, and then you sacrifice the mouse, and then you culture the lungs and the spleen. And if you detect any growth, that's called a relapse. So it's very sensitive.
Yeah, and then my second question is this is actually
I want a little bit of perspective from your pulmonologist, or if I'm not saying that. So previously, before working here, I'm working at a company as a company doctor. So like I check if the employee the medical checkup of employee every year, and then I find it hard or like a bit confused whether or not if I need to like you as a company doctor you need to make sure that the patient is safe for in safe condition to work, right? And then like for those with EGRA positive patients, like they need to get this TPT. And then the question is should it like can we can you speak in bahasa Indonesia? Sorry. Yeah, bahasa Indonesia. I'm sorry, bahasa
No,
Indonesia.
go ahead.
Yeah.
Boleh Kak.
Boleh Kak, selama masih TPT, kayak kita tuh
Cutikan.
enggak membolehkan si pekerja itu masuk untuk bekerja, like without tidak khawatir bahwa si infeksinya ini bisa nyebar kemana gitu, like while getting the TPT.
Okay.
Ini masih jawab aja.
Boleh dong, boleh dong, boleh dong.
Someone with latent TB and during TPT is not infectious. No symptoms. So why? No symptom lah.
Is it different with asymptomatic?
No, it's not different. Yeah, TB disease.
Like latent and asymptomatic. Like I heard there's a research in asymptomatic TB, right?
Yeah.
So like, is it different? Latent?
No symptoms.
So,
Yeah. So,
Can I
but
comment?
you can, yeah.
Nah,
So-
Profesor
The true professor.
Thank you for your question. So yeah, it's also, you have to sort of think of TB as a bit of a continuum. So there are people with cavitary disease, there are people with minimal asymptomatic, but still there's TB bacilli there if you do sputum. And then there's people with abnormal X-ray, but nothing, no sputum, nothing in their sputum. And then there's people with normal X-ray, but still positive or positive TST. And that's a continuum. And people can have like an abnormal X-ray and then sometimes a positive culture and sometimes a negative. And we call that inactive TB, but some people call it asymptomatic TB. So TPT is at the end of the spectrum where there's very little bacterial burden. And we usually define that as stable chest X-ray. So it could be abnormal, but stable, and negative sputum tests. So they're certainly not contagious. So that's for TPT, and then TB disease is positive sputum tests or an evolving chest X-ray, and onward from there. Yeah, but you can have TB disease without symptoms. You can't really have latent TB with symptoms. Definitely not. But you can have TB disease without symptoms, or with such minimal symptoms that they don't notice it.
Can clear the questions.
Yeah.
Okay, enough. Marcel has another one.
Sure.
Yeah.
Sorry if anyone wants to ask. I'm wondering on the endpoints. So all of these preventive therapy that have been done for almost a long time.
70. Ini 2020.
Yeah,
Ini
75 years,
76.
yeah.
76 years.
Have anyone been looking at, and how long we usually wait for active TB cases? 2 years?
2 years.
2 years.
Has anyone dived deeper into like a shorter progression biomarker, as in not related directly to the, it is related directly to the active TB cases, so that you can switch out easier, faster, and you can try more things. Let's say RISC-11, let's say RNA transcript. So some of those things that is, what do you think?
Sure. Sure. So again, interesting questions. So there's a lot of interest, obviously, in biomarkers that would identify, first of all, that would help us with latent TB trials. We could shorten the trials, do them faster with fewer people. So far, and there have indeed been proteomics and risk profiles. In South Africa, they had something that looked very promising, but didn't pan out in the end. There are culture-free
Cell-free DNA,
and so on. So these are biomarkers that are constantly evolution, but up till now, no. We're still stuck with these massive 2 years of follow-up, 3,000 people per arm kind of trials. So that's why we're looking at trying to get really to the shortest and safest regimen before we take it to phase 3, rather than do the other way around. People have done phase 3, and then they even launch the drug, and then it crashes over safety. So we're kind of thinking safety is actually the most important biomarker.
Makes sense. I think last question will be maybe Prof. Rosina could answer this. Is it currently status in Indonesia that we give TB preventive therapy without measuring IGRA? Yes. So that's the answer is yes. And what will it relates to antimicrobial resistance? As in maybe giving it without looking at, so let's say 1% active TB cases and in a household contact will get PPT without any IGRA.
Okay, so just to be clear, so IGRA is to detect TB infection.
Yeah.
But TB disease, you can't detect with IGRAs or TST, right? Because they're positive whether you're infected or diseased. So for that, you have to do symptom screening and chest X-ray. So that people are doing. And if you do that, if you do only symptom screening and chest X-ray, then all of the studies that have done that have failed to show any emergence of resistance with TBT. That's been looked at carefully in large-scale meta-analysis. If you don't diagnose correctly, so you don't do a proper chest X-ray, you don't do a symptom screen, okay, then you can lead to an emergence of resistance because you miss disease. And you mistreat disease with the wrong treatment. But that's a diagnosis problem.
Yeah, I mean, I'm more intrigued into other pathogens, whether using a preventive therapy that is not focusing only on IGRA positive patient will it affect not only TB, as in like more broadly antimicrobial resistance on
I see.
On other pathogens. So I mean, we are I think as Indonesia is trying to give more TPT, it blindly gives to everyone without even looking at IGRA status. It will be
not to everyone.
Not to everyone.
Not to everyone, especially for below 5.
Yeah.
If the facility is not available, so jadi lebih banyak manfaatnya memberikan TPT pada balita, ya, tapi simptom basic screeningnya harus benar dibanding mudaratnya. Jadi tidak untuk orang dewasa yang nggak usah diingat.
So in that we still wait for IGRA results.
So I think the problem there is that if you treat people unnecessarily, I mean, of course, the problem, my view is the problem is greater of the individual. There's no individual benefit if you treat someone who's IGRA negative. There's no benefit. There's only the risk of side effects. Now, the population risk of broad application of TPT, for example, in terms of microbial resistance. First of all, if you're using very specific TB drugs, they should, they're quite narrow spectrum. So Levo is an exception.
Yeah,
that's a more broad spectrum antibiotic. However, I would say that, Levo uncontrolled use I think in this country as well, right? Anybody can prescribe it. There's no controls. So we've actually seen an emerging Levo resistance in TB patients because of community use of Levo for everything. So that's more the problem, I think.
Yeah. Okay. Thank you.
TPT.
Okay. I think Marcel has
And
still
then
has a lot of
2000
question, 2000 question,
Okay.
then you can continue talking and discussing, discuss with Lika and
Sure.
Prof. Nina if you want, or me, if you think I can answer the question. I don't know. Yeah. Kalau dari yang online tidak ada pertanyaan. Saya pikir tidak ada ya, karena kita sudah 15.30, sekitar 16.30. Tapi nanti kalau ada pertanyaan, if there any question to Pak Dik or bisa juga ke Prof. Nina, silakan ya langsung ya. So thank you so much. Prof. Dik, we are just like following the history of finding good treatment, better treatment for TPT. Jadi kayak nonton sejarah ya. We are just like watching a video of the history of the TPT starting from 1950, starting from 12 months of INH, and then just only one injectable long acting ya. Jadi kayak vaksin ya. More or less it's just like vaccine, right? The one shot, sorfequilin and bedaquiline LI. Ya, long acting. Jadi ini sesuatu yang masih kita tunggu. Vaksin M72 juga sama, kita masih menunggu hasilnya, efekasinya dan lain-lain. Dan ini juga yang kita sedang tunggu, gitu ya. Prevention is better than apa? Cure? Kuratif. Ya. Jadi hashtagnya adalah kita lebih baik mencegah daripada mengobati. Tadi satu lagi, tadi kita bicara ini mah promo ya, promo marketing for of the master program of epidemiology in Faculty of Medicine Universitas Pajajaran. That from the story, we learned that there is specific design, that have to be used to prove the intervention, gitu ya, whether the intervention is better than the standard care. Jadi tadi kita mendengar ada RCT, Randomized Trial. Kita dengar apa lagi tadi? Animal model ya, mouse model to help the clinical trial. Kemudian ada systematic review dari RCT. Jadi dari beberapa RCT for like 20 RCTs or more, we can have the conclusion, because sometimes the result is different from trials to trials, so we can combine the result using the systematic review and meta-analysis, and also we can look into more detail using the IPD, and then also with the network meta-analysis. Yang tadinya nggak ada di studi-studi itu di compare, kita bisa membuat model untuk comparing. Yang penting ada networkingnya, gitu ya. Jadi dari trialnya nggak ada kayak satu HP tuh nggak ada yang dibandingin dengan misalnya dengan satu di treatment. Tapi dengan networking meta-analysis kita bisa membuat itu menjadi seolah-olah ada studinya. Jadi dari tadi beberapa study design itu, teman-teman kalau ada yang tertarik, teman-teman bisa ikut join di TP Clinical Trial Unit di bawah leader Prof. Nina, ya, bergabung dengan kami, atau bisa mengikuti program S2 EPID, karena di situ kita belajar tentang epidemiologi klinik ya, dengan uji klinik. Jadi kalau teman-teman tertarik menjadi clinical trialist, you can join us. Itu ya promonya ya. Berhasil nggak? Sukses. Berarti ya mudah-mudahan kami bisa menjaring mahasiswa. Mudah-mudahan bisa dapat beasiswa. Ya, amin.
Khusus menyediakan beasiswa.
Ya, mudah-mudahan ya Pak Bakti ya, dengan khusus nanti ya Pak Bakti.
Dengan bantuan para PI.
Dengan bantuan para PI tentu, kami akan sediakan beasiswa ya. So we also for the scholarship and working with McGill University, we also have several benefits by sending many staff to do the online course or the offline course. I mean in person in McGill University. Both of us and some of the PI, dan Prof, Dr. Boni, Dr. Alit, siapa lagi, Panji, ya kita udah ke sana to get Dr. Amai juga ya, Dr. Amelia di sana ikut program dari McGill University. Jadi there is opportunity to improve, to increase our capacity with this collaboration. Ya, tanpa bertambah-tambah lagi nanti maghrib pulang. Kita bisa tutup ya, we can close this guest lecture. Again, thank you so much, Prof. Menzies. Thank you, Prof. Nina. Thank you. Ini dua guru saya ya, dari saya masuk ke Pusris. Mudah-mudahan teman-teman bisa sama-sama belajar. Terima kasih. Kita tutup dengan hamdalah. Alhamdulillahirobbilalamin. Assalamualaikum warahmatullahi wabarakatuh. Door prize gimana?
Terima kasih juga ke panitia.
Iya panitia. Terima kasih Ui Jija. Grace. Terima kasih banyak. Terima kasih teman-teman yang sudah join di grup di Zoom. Terima kasih kehadirannya. Kita ketemu lagi lain waktu. Terima kasih atas semuanya.
Ya, tingkat paparannya di SS lagi kayak HIV.